Hi everyone, I'm Dr. Arland Hill, and today I want to go over MTHFR. MTHFR has become a little bit of a buzzword, so I want to make sure we all have a consistent understanding of exactly what MTHFR is and what it's doing in our body. And for those individuals that have defects or SNPs, so what are the acronym for single nucleotide polymorphisms, or what is generically sometimes thought about as a mutation, if someone has one of these, what can we do about it, or what can we do to support someone with this scenario? So first of all, let me explain what MTHFR is. MTHFR is an enzyme, and it's most importantly known as the enzyme that's going to finalize the step from taking inactive folates over to active folates. Most of the folates that we consume from our diet, and it's important to recognize here that we're not at this point speaking about folic acid, but specifically folates, the more bioidentical form. The active or the inactive folates have to be converted over to active forms of folate so that they can adequately be utilized, and so that the methyl group found in that active folate can then be donated further into the methylation process. So when we specifically talk about MTHFR's sole role is to convert inactive forms of folate over to active forms of folate. That's predominantly what it does in the body. Now, that's important because we know now from bodies of research that there are several things that can be affected by having aberrations in the MTHFR enzyme. Such things are going to include depression, anxiety, cardiovascular disease, impaired detoxification, increased susceptibility for autoimmune conditions. So there's a number of reasons that we would want to know what someone's MTHFR status is. So with that said, let me go into a little bit more detail, specifically looking at the dynamics of this and walk you through this process. But let me also, we'll get into what are the two gene locations that we need to know most specifically about, and what do we do about those. So what we're talking about here at this point is we're looking at the folate cycle. And when we look at the operation of the folate cycle, we bring folates in, and folates are either going to come in through, again, our diet, or they can come in through a supplemental form. We're not talking about folic acid here. Folic acid can enter into this process, but there are a few conversions that have to happen for folic acid to ultimately come to tetrahydrofolate before it can convert over to tetrahydrofolate. There's a few steps that have to take place to make that conversion. Once you're at tetrahydrofolate, you're going to convert around through a few more steps until you ultimately get to something called 510 MTHF, or 510 methylene tetrahydrofolate. MTHF is fine. This is also what's known as folinic acid. This is the last step of the active folates, or the inactive folates, before they become active. So to take this inactive 510 MTHF or folinic acid and convert it to its active form, 5-methyl tetrahydrofolate, or what we see sometimes supplements being formed around, you have to use MTHFR to make that final conversion. And then ultimately that does give you your 5-MTHF, your active folate, and then this active form of folate, which has the methyl group, can then in turn donate that methyl group into the methionine cycle to ultimately allow for production of the free methyl group to have, or to carry out, its various roles in the body. So when we look at what are the things that are going to directly influence MTHFR, when you look at this from a genetic standpoint, there are on the order of between 40 and 50 different genes that have the ability to influence this enzyme. And most people don't have every one of these genes. You're going to see variability in which ones they have. The two of the ones that are most well studied are going to be 677 and 1298. Now, of these two, the 677 probably has a little bit more influence over MTHFR. And the reason that it does is because of where it's located. So if we think about this as, I always sort of think about it in terms of just a long line here. And if we're looking at the ability for B2, which is the cofactor for MTHFR, it's the actual nutrient that the MTHFR enzyme needs to function efficiently. What's happening here is that when we have mutations in the genes, they affect the coding of this enzyme, and they make it more difficult for B2 to stay attached to the enzyme to keep it active. Now, The reason that 677 likely has more impact is because 677 happens or is more influential towards the middle of that enzyme. So it's going to have a greater impact on the overall structural configuration of the enzyme than does 1298. 1298 is going to be a little bit further out towards the end of the coding sequence. But again, they both have direct effects here. So for example, when someone has a mutation is 677, they may be, depending on what their profile is, they may have a higher predisposition for having elevations in homocysteine if they don't have adequate folate available to support that or to overcome the enzyme variant here. Now, when you talk about the different options that you can have for what kind of gene profiles can you have and what are the influence on these, when we look at each one of these, you have a couple of outcomes that you can have. So for example, you can have what's known as a negative profile. A negative profile means that you had the ideal gene from both mom and dad and you're not having any mutations at that particular location. You can have the same thing in 1298. These are essentially the options you have for any gene. So you can have what's known as a homozygous ideal pattern, or what would be termed a negative. You can have a heterozygous pattern, which we would note as a mixed pattern. And for 677, when we have a mixed pattern, when we have a mixed 677 here, we're basically looking at around about a 30 to 40% loss of activity with a mixed pattern here. So you still have one good gene from mom or dad, but mom or dad gave you also one bad gene in this scenario. So your coding makes it where you switched up your coding and you put a different amino acid in the sequence and it changed the overall structural configuration such that B2 doesn't want to stay in as close a contact with, it doesn't want to stay in the receptor side as efficiently in the MTHFR as if someone had a negative profile. Now, let's go to a more extreme example on this for 677, and you can have what's known as a homozygous pattern, or what we think about as maybe a plus-plus. A homozygous pattern, if you have a 677 homozygous where you end up with a plus-plus, you're going to have about 30% activity at MTHFR as compared to the normal population, or what's known as the wild type within the population. So that's pretty significant for just one mutation that can take place. And then when you add or compound the effects of 1298 into this, it becomes even more significant. Markers, when we look at this, the way we want to follow through to see how we need to interact on, or how we need to follow through with maybe a treatment intervention for these particular gene locations, is we look at markers such as homocysteine. We know that when 677 has an aberration or has a mutation there, there's a higher likelihood for an increased level of homocysteine, but that effect can also be compounded to some degree with 1298 as well. So we don't want to just look at the gene and take an action just based on what the genetic profile is. We want to try to assess if that genetic profile is actually having an effect on the physiology somewhere, and if it is, then we take action on the impact of the physiology with the gene in mind. So it's important to know. A couple of things, so I mentioned homocysteine is one way to assess this methylation process, which is ultimately what we're talking about here. We can also do it with the mean corpuscular volume, or what we a lot of times just look at as the MCV on a complete blood count. That's another way to do this. One other piece of the puzzle that we want to look at in regards to looking at specific things that we can do. Some individuals can benefit from just folinic acid. Maybe there's a deficiency in folate and we just need to funnel some more precursors into the system to have adequate folate status to be able to push past MTHFR. We can also note, I mentioned B2 earlier. B2 is the cofactor for MTHFR. A deficiency in B2 will cause inactivity at this enzyme location, as well as the other points where B2 is involved. So you wouldn't convert into this active form of folate. And then certainly in some scenarios, we know that we need to bypass this process completely. Maybe we have someone who has a more severe depressive state, or maybe a more severe clinical condition where using active forms of folate for an extended or a shorter period of time, depending on the presentation, would be necessary, and these are available to utilize as well. Now, I want to reiterate the point that this is not, when we talk about MTHFR, MTHFR is a piece of the methylation puzzle. It's not the methylation puzzle. It's only a fragment. It's probably the more important enzyme in this bigger process. So in some ways you could think about it as the keystone to methylation. But I also want to highlight the fact that we want to make sure that we have the environmental, or in this case, some of the nutritional components that we need to carry out the entire methylation process here. I've put up a list of some of the ones that tend to come up most significantly or that are cofactors in these pathways and that can be shown up to be deficient. So serine, magnesium, zinc, B6, B12 choline, folate, B2. It's important also to recognize in this list, a deficiency in any of these could inhibit the entire methylation cycles, the folate cycle and methionine cycle together. But it's also important to note that you need to have a way to be able to assess B12 status if you're looking at supplementing folate, because the two have an antagonistic relationship in regards to supplementation, meaning that an oversupplementation of one of those two nutrients can cause a deficiency state in the other one, and it works for both nutrients both ways. So an important point to remember on this. So, when you're thinking about patient care, or when you're thinking about, well, how maybe you're a patient out there and you're thinking about, well, what do I need to do for MTHFR, or what do I need to do to understand this? These are the things that you need to know to have a good basic understanding, but you got to look at the genetic profile and look at the nutrients that influence the gene profile and not just the genes themselves. I want to thank you for taking the time to listen. Again, I'm Dr. Arland Hill.